reached in time, though it was pouring cats and dogs. So without wasting much time, let me just continue with my talk today. And the talk is on postpartum hemorrhage. Postpartum hemorrhage, we have heard on many forums, and I would say it is done to its exhaustion. But still the confusion remains, especially with regards to prevention of PPH. There are lots of things that people talk about, and have seen a big debate between two giants on a big platform in one of the conferences, whether to do the removal of placenta immediately after giving oxytocin or not, whether to wait for the separation of placenta or not, whether to give oxytocin IM or IV, whether to give any other drugs. So today I'm trying to resolve once for all these issues, I hope, in next 15 to 20 minutes. Though the title is Carbitocin in Prevention of PPH, I would not restrict myself to Carbitocin as such. I will definitely talk on that, but I will be talking, or rather clarifying, which are the drugs that we must give for the prevention of postpartum hemorrhage, because this is a very important issue. So, as we all know, the etiology of PPH is stone, trauma, thrombin, and tissue. This is the undergraduate stuff. Today, I'll be concentrating only on the first part, the postpartum hemorrhage due to atonicity, and can we prevent that? I'm definitely not going to talk on trauma, and thrombin, Dr. Uday Thanawala will be talking, and as far as tissue is concerned, it will be for another day. The atonic PPH constitutes the highest cause. Up to 70% of the cause, more than 2/3 of the cause is atonicity. And this can occur in anybody and everybody. This may not be exactly due to the negligence of an obstetrician, whereas trauma, I can say that probably we mishandled the case. Tissue, of course, again, is because of the adherent placenta and other things, and thrombin, of course, again, a complication. But atonicity is the one which can occur universally, and that has to be prevented. And all the research has gone in this direction. That's how the WHO came out with what is called active management of third stage of labor way back in 2012. And in 2018, they reiterated the same thing. So there is nothing actually really new in this. However, I'm here to clarify certain issues. Number one, the WHO is always smart and it is generous. It doesn't really bog you down to a particular thing because it has to take care of the whole world. It cannot be only concentrating on first world countries. It has to concentrate on very low resource settings. That's why they are using the word uterotonic rather than telling any particular drug. And they say immediately after delivery. Now, there can be a big controversy in this, whether to give at the time of delivery of anterior shoulder of the baby. Now, the joke goes, one of the interns gave it to the anterior shoulder of the baby itself, rather than giving it to the mother. So then they said whether to give it after the delivery. If it is after the delivery of the baby, how, within what time, whether to give IV or IM. Some people think that it should be given after the placenta. That is wrong. That is not preventive measure. The second one, as I said, controlled cord traction. Again, some people argue saying that you give this side oxytocin or whatever uterotonic you like, and that side you start pulling the cord. That is probably okay if the placenta has already separated, but it is always prudent and wiser. Okay, let me put it this way. I would rather wait for the separation of placenta so that when I pull with a control, it will easily come out instead of snapping the cord and getting into traumatic postpartum hemorrhage. Or should it be a case of adherent placenta, I would be causing the inversion of uterus. We may argue saying that we should be able to make out adherent placenta by ultrasound. Sometimes we will have surprises. A case may be an unbooked case. So it is always wiser to wait for controlled contraction till the signs of placental separation appear. The third thing is again controversial. Massaging the uterus. WHO has clearly told it is not needed if uterotonic is given. Only if you have not given uterotonic, or if there was no time, then you need to massage. Or if the delivery has occurred at home where you could not get onto the uterotonics, then massaging is okay. So I hope I am clear about these three simple tests, and I hope I have rested the arguments. Now let me talk more about the uterotonics. WHO recommends use of an effective uterotonic. It doesn't prescribe really anything in particular. It simply uses a very qualitative word called effective uterotonic for the prevention of PPH during third stage of labor for all births, whether it is vaginal or abdominal. Number two, to effectively prevent PPH, only one uterotonic should be used. Don't make a cocktail of all the uterotonics. We are talking about prevention of PPH. We are not talking about management of PPH. There probably you may use alternatively one uterotonic after another. But as far as prevention is concerned, only one uterotonic should be used. Now, as I said earlier, WHO is not biased. It says you can use either oxytocin, carbitocin, misoprostol, ergometrin, or methyl ergometrin, and oxytocin and ergometrin fixed dose combination called symptometrin. Now comes the question of efficacy and safety. So WHO gives very good recommendation again. It says the use of oxytocin 10 units, IM or IV. But here one caution I would like to give. If you are giving IV, please give it very slowly. Otherwise, there can be sometimes sudden hypertension. IM is better because you don't have to wait for a vein. So WHO says either IM or IV is recommended for the prevention of PPH for all births. It comes under the category of recommended. Second, the use of carbitocin 10 micrograms IM or IV again is recommended for the prevention of PPH for all births. Note these words, in contexts where its cost is comparable to other effective uterotonics. So what is the recommendation? Context-specific recommendation. Number three, the use of misoprostol, either 400 micrograms or 600 micrograms per oral, but we now know that it can be given per rectal as well if the mother cannot swallow, is recommended for the prevention of PPH for all births. It comes under the category of recommended. Then the use of ergometrin or methyl ergometrin. When I was a PG and till recently, maybe till 5 years ago, we were using ergometrin. 200 micrograms IM or IV again is recommended for the prevention of PPH, but we always prefer to give IV, this particular drug. Otherwise, there was some sort of a necrosis. Again, it is context-specific recommendation because in hypertensive disorders, it should not be used. The use of fixed dose combination of oxytocin and ergometrin, which is symptometrin, 5 international units or 5 and micrograms combination, IM, is recommended for the prevention of PPH in contexts where hypertensive disorders can be safely excluded. But again, it comes under context specific because of ergometrin combination. And finally, there was a lot of confusion in one of the conferences whether carboprost can be given for prevention. No. WHO clearly says injectable prostaglandins are not recommended for prevention of PPH. It may be given for control of postpartum hemorrhage or management of postpartum hemorrhage. Now comes when there are so many things recommended and contextual recommendations, how do you choose? Again, WHO has clearly given us the choice. It says in settings where multiple uterotonic options are available, oxytocin 10 units IM or IV is the recommended uterotonic agent. for the prevention of PPH for all births. So oxytocin is recommended. As far as the question of it's not available or its quality cannot be guaranteed, the use of other injectable uterotonics, that is carbitocin, argometrin, methyl argometrin, or oxytocin argometrin fixed dose combination, or misoprostol is recommended for the prevention of PPH. So here comes the question of its quality cannot be guaranteed or it is not available. Finally, when it comes to the settings where skilled health personnel are not present to administer injectable uterotonics, the administration of misoprostol 400 micrograms or 600 micrograms per rectal or per oral by community health workers and lay health workers is recommended for the prevention of PPH. That means they do not know how to give injection. So now comes the challenges with uterotonics. Already you know that oxytocin has the drawback it need for appropriate training to clinical staff, regular patient monitoring, shorter half-life, and need for other uterotonic agents after this. Oral misoprostol, higher risk for severe PPH, increased need for additional uterotonic, greater incidence of nausea, vomiting, diarrhea, and shivering when you use it for prevention. Symptometrin combination, significantly increased risk of elevated BP, nausea, and vomiting. And finally, ergometrin, significantly increased nausea, vomiting, and it cannot be given in cases of preeclampsia. So that's why the question of the rationale behind heat-stable carbetocin comes into picture. We need refrigeration for oxytocin. We have to keep it in fridge because it is not heat stable. The earlier version of carbetocin was also not heat stable, that needed refrigeration. And resource poor countries do not always have cold chain transport and storage capabilities. That's exactly why the newer generation of carbetocin came into picture, which is stable at room temperature. That's the most important part of it. Has shelf life of 24 months at 30 degrees centigrade and 70%, 75% humidity. It avoids need for cold chain storage and logistics and is provided in a vial form. So you can straight away take it from the vial and give, there is no need of doing any other calculations. Carbetocin is available in a room temperature stable formulation and convenient vial presentation. So it's a next generation drug, I can say, because it is actually oxytocin, but it's an analog of oxytocin. Carbetocin was created by making several modifications to the oxytocin structure. It prolongs its half-life and decreases or reduces the enzymatic degradation. It is a synthetic long-acting analog of oxytocin. Indication being same, that is prevention of postpartum hemorrhage due to uterine atonicity. And administration is very simple, 100 micrograms of carbetocin in 1 ml of solution for injection, ready for injection, IM or IV. But one caution, if you are giving IV, you have to give it very slowly. This is the latest article that we have found. Carbetocin, how does it act? Of course, there are so many methods of action. It's almost like oxytocin. So all I want to tell is that it's a single IV dose of carbetocin, 100 microgram administered after the delivery of the baby is sufficient to maintain adequate uterine contraction, preventing uterine atony and excessive bleeding with efficacy comparable to hours of oxytocin infusion. So what are the benefits versus oxytocin? Reduced need for additional uterotonic agent. One injection is all that you need. Longer half-life, that's the reason. Similar efficacy, of course we need it. Similar onset of action and good tolerability. So this is the comparison, and the conclusion is that a single injection achieves uterine activity within 2 minutes and lasts for 1 hour and can increase the rate and force of spontaneous uterine contractions. The another big advantage versus oxytocin is that carbetocin is 24-fold less potent than oxytocin as far as vasopressin receptor reducing the risk of hyponatremia. As a uterotonic, it's very potent, but as a vasopressin reducing the risk of the hyponatremia is the advantage of it. So though it has got similar structure as oxytocin, it has this advantage, that is, to date, no case of hyponatremia has been reported for carbitocin. The champion trial is the one which brought carbitocin to the forefront. The champion itself means Carbetocin hemorrhage prevention trial. And the study design was non-inferiority randomized trial. Objective was to compare the effectiveness and safety with vis-a-vis oxytocin, and patients, can you see that 30,000 women across 10 countries, including India. And primary outcomes were the proportion of women with blood loss of at least 500 ml or the use of additional uterotonic, and the proportion of women with blood loss of at least 1,000 ml. What is the result? Carbitocin non-inferior to oxytocin. Single dose carbitocin versus oxytocin infusion. Oxytocin, for a sustained action, you have to give in an infusion of 20 units in a 500 ml after giving the preventive dose. And this will take a long time of 5 hours. So hemodynamic effects of oxytocin and carbitocin were compared, and their efficacy was assessed in terms of blood loss, additional uterotonic needed in cesarean section. So this was the study, Carbitocin 51 subjects and oxytocin 51 subjects, and they studied the BP drop and the blood loss in terms of drop in hemoglobin. What's the result? Carbitocin and oxytocin have a hypotensive effect. Yes, both of them have that. But women treated with oxytocin showed greater reduction in blood pressure. Significantly more women treated with oxytocin needed additional uterotonic agents compared to those treated with carbitocin. Patients treated with carbitocin showed better uterine contractility at 2, 12, and 24 hours with statistically significant difference. So the verdict is a single injection of carbitocin was found to be more effective than continuous infusion of oxytocin in preventing PPH. Finally, I end with the Cochrane review. Usually, Cochrane review does not come out with very clear conclusions, but here it says it's a promising agent. Efficacy of carbitocin was checked against conventional uterotonic agents for the prevention of PPH. Carbitocin was compared with oxytocin, symptometrin, or placebo when given IM or normal after normal vaginal delivery as well as cesarean delivery. And the clear verdict is carbitocin is effective compared to other conventional uterotonic agents. Statistically significant reduction in the need of therapeutic uterotonics compared to oxytocin in cesarean deliveries, reduced need of uterine massage compared to those treated with oxytocin after vaginal or cesarean delivery. In fact, WHO says there is no need to massage after giving a uterotonic, and lower risk for PPH, and finally, lower blood loss compared to those treated with symptometrin. So, carbitocin is here as a promising agent with a convenience of single dose therapy of 100 micrograms given soon after delivery of the baby within 1 minute preferably to prevent postpartum hemorrhage. Thank you very much.